Okay, picture this. You're on call in the NICU. You've got a newborn who is totally healthy, full term, and then bam, they're lethargic, vomiting, and have a really severe acidosis. Now, sepsis is always on the list, right? But what if it's something else? What if you're dealing with a full-blown metabolic catastrophe? All right, let's dive right into this exact scenario and talk about organic acidemias.
Here's how we're going to break it down. First, we'll get into the clinical mystery of that crashing newborn. Then, we'll talk about how to crack the code diagnostically speaking. We'll meet the three main culprits you'll see. After that, we'll run through the emergency crisis playbook. And finally, we'll look at what life looks like beyond that initial crisis.
So let's kick things off with that classic presentation. I mean, this is the scenario that keeps all of us on our toes, right? The baby who looks absolutely perfect, and then within hours becomes one of the sickest kids in the entire hospital. This right here is what we call the lucid interval. It's so deceptive. The baby is born, looks great, starts feeding normally for maybe a day, maybe two. And then there's this sudden catastrophic nosedive. That pattern is a massive red flag that you're looking at an inborn era of metabolism.
So what is actually going on inside this little baby? Well, organic acidemias are genetic disorders where a really critical enzyme just isn't working. This single defect sets off what the sources call a cascade of biochemical effects, which basically means there's a huge buildup of metabolites that act like powerful endogenous toxins. The baby is literally being poisoned from within.
So the clinical picture you see is this very distinct group of findings. You've got this rapidly worsening encephalopathy, severe ketoacidosis with a high anion gap, but it's a true multi-system attack. It also causes really high ammonia levels. It can suppress the bone marrow. And sometimes you even get these really unusual odors.
Okay, let's make this real. You get that exact call from the floor. A 3-day-old, lethargic, not eating, with a bad acidosis. Sepsis is, of course, number one. You have to rule that out. But with this whole picture, especially that timing after a lucid interval and just how sick they are metabolically, an organic acidemia has to be right at the top of your differential.
So you're suspecting it. How do you actually prove it? Let's talk about cracking the code. Your diagnostic evaluation has to be systematic, it has to be staged, and most of all, it has to be fast if you want to prevent permanent damage.
The approach is really twofold. First, you get that initial metabolic screen. These are the basic labs you can get in pretty much any hospital, and you can get them fast. At the same time, you send out the specialized biochemical tests that are going to give you that definitive diagnosis.
So your initial labs are going to give you some huge clues. High anion gap metabolic acidosis, that's the classic finding. A plasma ammonia level over 200, that's a major red flag for this kind of metabolic intoxication. And here's a really key point. You will see large ketones in the urine. That's a huge differentiator from something like a fatty acid oxidation defect. That ketonuria is a really strategic finding.
But the single most important test, the one that actually names the disease, is the urinary organic acid analysis. This is the one. This is the strategic study that identifies the specific pattern of acids building up and tells you exactly which disorder you are dealing with. All right, now let's meet the three most common culprits that show up in the newborn period. We've got isovaleric acidemia, propionic acidemia, and methylmalonic acidemia, or as we usually call them, IVA, PA, and MMA.
This table really lays out the key differences beautifully. So first, look at the newborn screen markers. IVA will pop with a C5 acylcarnitine, but PA and MMA both show a C3. Now clinically, IVA is famous for that classic sweaty feet odor. PA and MMA can look pretty similar at first, but they have their own unique long-term risks. PA is known for causing basal ganglia infarcts and cardiomyopathy, while MMA is really notorious for leading to progressive renal failure. And, super critically, some forms of MMA can actually be treated with vitamin B12.
And I just have to say this one more time because it's such a classic board exam question and a real-life clinical clue. That sweaty feet odor is an absolute hallmark of isovaleric acidemia. If you ever smell that, your brain should immediately scream IVA.
Okay, so the diagnosis is made, or you're at least pretty sure you know what's going on. Now what? Let's get into the crisis playbook. This is all about immediate, decisive action. The clock is ticking. You have to treat this as a true medical emergency. Your number one goal, above everything else, is to slam the brakes on that biochemical cascade of intoxication as fast as you possibly can. Every single minute counts. So how do you do that? What's the brake pedal?
The single most important thing you can do is shut down catabolism. That's the body breaking down its own proteins for energy. And you do that by giving a high glucose infusion rate, or GIR, of at least 10 milligrams per kilogram per minute. This flips the body's metabolic switch from a breaking down state to a building up, or anabolic state.
And this is just as critical. It's completely non-negotiable. You have to stop all protein intake immediately. The amino acids from that protein are literally the fuel for this metabolic fire. You have to cut off the source.
So beyond just stopping the fuel, you have to actively remove the toxins that have already built up. For really severe cases, hemodialysis is the fastest way to clear out that ammonia and those organic acids. We also use specific scavenger therapies. Carnitine is absolutely essential for getting rid of toxic acyl groups. And we give specific cofactors, like giving a trial of vitamin B12 for suspected MMA, and something called glycine for IVA.
All right, you've stabilized the acute crisis. You've pulled the baby back from the brink, but the work is far from over. These are lifelong conditions, and they require really careful, chronic management. This is a marathon, not a sprint.
So the cornerstone of long-term care is a highly specialized diet that restricts the specific amino acids that cause the problem in the first place. For PA and MMA, we also use antibiotics to suppress gut bacteria that can make things worse. And you have to be constantly vigilant, watching for those long-term complications we mentioned, like renal failure in MMA, which can sometimes even lead to needing an organ transplant.
So to wrap all this up, I want to leave you with a thought about the future. Newborn screening is catching more and more of these kids before they ever have that first catastrophic crash. So think about it. How does that change our job? How does our role shift from being emergency responders to becoming proactive managers of a chronic disease? How do we focus on preventing that first crisis altogether and optimizing their development for the long haul? It's a really critical question for all of us in this field.